Good afternoon, everyone, and welcome to our Fall 2015 CPT An webinar session, the first of this academic year. I am Leo Brando, and we are using a program called GoToWebinar to webcast this session. Before we begin, please allow me to share with you some housekeeping details to assist in everyone's participation. As always, at the end of the session, we will have a Q&A session by region. And because I can see who has logged in, I actually will ask centers by their location. If there is any question verbally, or alternatively, you can send us questions via the webinar and I will be able to read it to our speaker. Now, talking to the CKids team in the clinic conference room, please, during the Q&A session, we kindly ask you to come up and ask your question using the white microphone in the podium so that your question can be heard clearly. We also ask if you wouldn't mind please keeping the noise level to a minimum so that does not interfere with the webcasting. At the end of the session, an evaluation survey for this session will appear in your screen. Please take a minute to complete it so that we can keep this as a CME accredited session. The final reminder is if you require any technical assistance, please don't hesitate to contact us directly by calling 416-813-7654 extension 205401. Now let me introduce the speaker of our session today. Dr. Cindy Nunert has been faculty of Columbia University Medical Center, New York City, since this year, as a matter of fact. Dr. Nunert is an assistant professor of pediatrics at Columbia, and she received her fellowship training at Southwestern Medical School in Dallas, Texas, with Dr. George Buchanan. During her time there, she also obtained a master's degree in clinical science. She has been an avid and prolific participant at the American Society of Hematology. She was a CRTI trainee, and she has co-authored ASH evidence-based guidelines on the diagnosis and management of ITP in children. Additionally, she conducted a systematic review of the literature evaluating current tools used in ITP. Her main interest besides ITP lies in the area of hemostasis and thrombosis, and she has also worked closely with the ISIS group, describing the natural history of this condition in children. Today, we're going to have the pleasure of hearing Dr. Cindy Nunert talking to us about ITP, an old disease with new developments. And without further ado, I will have the pleasure of giving her the screen, if you will. Thank you very much and welcome, Cindy.
Thank you, Leo. It's a pleasure to speak with you all this afternoon about ITP, and there really, I feel, have been some new and exciting developments that we'll get a chance to talk about today. So just to give you all an overview of the objectives, I'd like to provide just a basic overview of pediatric ITP, but spend most of the time outlining the rationale for current management approaches. And then throughout the talk, we'll sort of weave in a highlight of national and international collaborative research efforts that are ongoing in pediatric ITP. So as many of you may know, pediatric ITP has a prevalence of 5 in 100,000. That makes it one of the most common things that we see as pediatric hematologists. It presents in a usually previously healthy child with no significant history. And the history is really one of just acute onset of bruising and petechiae, and some additional bleeding may be present, as we can see with this little guy here, where he's got some oral mucosal bleeding. And our physical exam should really be normal with the exception of bleeding findings. Our knowledge about ITP goes back to 1950, and this was some of our earliest knowledge from this brave man shown here, Dr. Harrington, who injected himself with 500 cc's of blood from a patient who had ITP. And what you can see is he developed a prompt decline in his platelet count that then showed some recovery over time. And what I like to highlight about this graph is that there's more than one line. So at some point he was able to recruit others to do the same experiment with him. But I like this quote by Schwartz in 2007 in the New England Journal that just said, "This experiment, one of the most important ever to be performed in the field of hematology, changed the meaning of I and ITP from idiopathic to immune." So at that time, our basic understanding was that there were these antibodies that were attaching to the platelet surface, and these were interacting with Fc receptors within the splenic macrophages, and thus preventing platelets and clearing them from circulation. But we've come a long way, and our understanding of the pathogenesis of ITP has really become much more complex. We now recognize it to be the result of a loss of self-tolerance at multiple various checkpoints. So what we know is that we get platelet autoantigens that are presented by our antigen-presenting cells, and these interact with autoreactive T cells. And under normal conditions, these T cells would be removed. However, in ITP or other autoimmune conditions, they go on to create our T helper cells that interact and stimulate our autoreactive B cells. And it's these autoreactive B cells that are producing the antibodies that are interacting with glycoproteins on the platelet surface, and as we've now come to develop greater understanding, are also interacting with glycoproteins on the surface of the megakaryocytes. And this will become an important fact as we begin to talk about some novel therapies for the treatment of patients with ITP. So despite our growing knowledge about the pathogenesis of ITP and new and novel therapies, there's still some sort of basic questions that exist in pediatric ITP. And the first is, should we treat children with ITP at the time of diagnosis and even later in the course of the disease? And what treatment should be considered for children who are unresponsive to initial treatment and or who have persistent or chronic ITP? And then in the absence of any substantial data, how do we make a good decision for our patients? So I'd like to anchor these questions with a case presentation of a 7-year-old who presents with a 24-hour history of bruising and petechiae and no additional bleeding. There's no family history of thrombocytopenia. Physical exam just shows some scattered petechiae and several bruises, but no other significant hemorrhage. And our complete blood count is very consistent with ITP in that we have an isolated thrombocytopenia, but the remainder of it is normal. And you're able to take the time and review the peripheral blood smear, and you see only a few large platelets with no other abnormalities. So our question really at this point is, should we treat this child with medication? So we have a couple options for the initial management of ITP, and these include observation and education, where eventually nature will cure the disease. We can provide corticosteroids that sort of dampen the antibody production process as well as impair clearance of our antibody-coated platelets. We can use IVIG, which provides a macrophage blockade. And then in addition, we have anti-D immunoglobulin, which basically works by sensitizing Rh-positive erythrocytes so that they then occupy the Fc receptors and our platelets get to kind of escape and come out the other side of the spleen, if you will. So why is observation a good option? Well, we know that from just the natural history that we'll get reduction or cessation of new hemorrhage within 3 to 10 days. And this is associated with a rise in the platelet count within 1 to 3 weeks. The platelet count will even become normal in about 50% of cases within 6 weeks, and then by 6 months is really normal in about 75 to 80% of cases. And unfortunately at this time we really don't have a lot of very good predictors of which patients are going to have normalization at which time points, but we should be encouraged that overall this is a very acute process in children. And recurrences are rare following remission in the absence of any drug therapy. So I do tend to reassure families that once this goes away, it's very unlikely that it would ever come back again. So if we were to put this all in a summary table, what we know is that observation and education, the dose is simply time, and the time to response is generally about 1 to 3 weeks. I throw in side effects such as anxiety. I think we have to gauge our families. Are they going to be comfortable at home watching their child? And then also, as I'll touch on in the next few slides, what's our risk of not treating this child, even though they're not bleeding now, with development of subsequent bleeding? Corticosteroids we're all very familiar with. Shown here is just the short course dose, which is preferred over longer courses in children. It takes about 3 to 4 days to show a response in the platelet count. However, there is some evidence that perhaps bleeding symptoms will start to show resolution even sooner than that. And the side effects over here are ones that we're all familiar with from using corticosteroids, and probably the one that the parents notice the most is the irritability. IVIG can be given in a range of 0.8 to 1 gram and works very quickly, as does anti-D. So both of these are good options if you have a child where you feel like you need to get a more rapid response in the platelet count, which will occur within about 24 to 48 hours. And the main side effect of IVIG is a headache, and this is important to keep in mind. It usually occurs about 24 hours after the infusion, and oftentimes results in children getting a CT scan because it's hard to tease out, with their platelet count still being low, what the source of that headache is. And then anti-D in the United States has an FDA black box warning because of fatal intravascular hemolysis. So it is important to note that you would expect about a 2-gram decline in hemoglobin because, again, we're sort of sacrificing red cells to save some platelets. And so to me, this isn't the best agent if your patient has already had a decline in the hemoglobin due to bleeding symptoms at the time of presentation. So despite all these options, we really still have no standard of care that's emerged as universal. There's very few randomized pediatric trials, and so there's generally different philosophical approaches that exist and are sort of based on individual experience. So some of the data that we can draw on, though, are these large cooperative natural history studies, and one of the largest comes from the Intercontinental Cooperative ITP Study Group, or the ICES, and Registry 2 was just one of their registries. And I really think they're to be commended for all their work. They were founded in 1997, and they are made up of over 500 physicians from 60 countries. And to date, they've enrolled about 4,000 patients on their studies. And their website is here just in case anybody is not familiar and would like more information or to perhaps contribute to their ongoing studies. So the aim of ICES Registry 2 was really to determine the frequency, timing, site, and severity of hemorrhage in children with ITP. And the time points that were chosen were primarily at diagnosis and then again in 28 days, because this was the time course during which it was really felt treatment at diagnosis would have the greatest impact. So there were 863 patients that had a bleeding severity assessment that was available at both diagnosis and 28 days. And shown here is just the diagnosis information. And I'd just like to highlight a couple things. The first is that the median platelet count is really not that different between the patients that had no or mild bleeding and those that had severe. So we might use 10,000 perhaps as a cutoff, but really all patients, the median was under 20,000. So it's really hard to have a clear-cut threshold under which we think every child with a platelet count of X is going to react the same way. We're just not really able to do that in pediatric ITP. And that data is shown a little bit differently here, but just to emphasize the point that if we looked at all patients, irrespective of their presenting platelet count, 77% had no or mild bleeding. And then if we look again at the group that might be considered by some to be more severe in their thrombocytopenia using a cutoff of 20,000, we see that number doesn't really change very much. It's still 74%. So regardless of the platelet count, the majority of children are going to present with findings of no or mild bleeding, and this was really defined as that which wasn't requiring an intervention or impacting the patient. And of this whole group, there was only one non-fatal intracranial hemorrhage at the time of presentation. So we became interested in what happened to this group, the group of 500, almost 500 patients that had a platelet count less than 20,000 and no or mild bleeding at diagnosis. So this is a group that would be receiving treatment specifically for the platelet count and not necessarily to stop overt bleeding at the time of diagnosis, and with the goal being to prevent further bleeding symptoms. So of this group, if we look forward at 28 days, only 3 or 0.6 developed severe bleeding, and of this group there was no intracranial hemorrhage. And even if we look at moderate bleeding, that only represented another 9 or almost 2% of patients. So really we feel like the development of severe hemorrhage is quite rare in children that have no or mild bleeding at diagnosis, even with a low platelet count. This data here just shows that there really was no relationship between initial therapy and the development of severe bleeding, but I would caution interpretation because you can see that for several of these, we don't have any patients and we had so few bleeding events that it really makes drawing any conclusions difficult. And actually the main conclusion of this work was that to conduct a superiority or non-inferiority treatment study, so if we wanted to show that treatment at diagnosis was powered in a way to reduce bleeding symptoms, what we found was that we would need 900 patients per study arm. And so it was just not felt that this was a feasible outcome for a randomized trial, even though it's really probably the outcome that matters most to us as clinicians and is likely what's driving a lot of therapy at diagnosis. So based on these findings, combined with the findings of other cohort studies and natural history registries, the ASH guidelines published in 2011 recommended that children with no or mild bleeding, defined in that document as skin manifestations only, be managed with observation alone, regardless of the platelet count. And this got a grade 1B, which meant that it was felt that it was a fairly strong recommendation with benefits outweighing risk, and the B represents that it was based on a moderate level of evidence. So the rationale behind this recommendation is a lot of what I've already talked about, but it basically was based on the backbone that the majority of children will recover their platelet count without drug therapy, that the incidence of severe hemorrhage is felt to be low both at diagnosis and later in the course of ITP, and there's no evidence to date that drug treatment at diagnosis goes on to prevent subsequent bleeding in patients. So if we come back to our young child 9 months later, mom is back in your office and now she's reporting a lot of intermittent epistaxis. It's not that long, but it's usually occurring during the middle of the day at school. The child's platelet count is ranging anywhere from 10 to 30,000. The boy is active and he wants to play soccer, and he's tried some first-line therapy, but unfortunately he had no response to IVIG. He's Rh negative and therefore not a candidate for anti-D, and he's had a decline in response to periodic corticosteroid use throughout the last 9 months. And the parents are here today really wondering whether the child can return to soccer practice, be more involved in things with his friends, and they raise concerns about the time lost from school and work, having to deal with these mild intermittent nosebleeds that are causing both him and him to lose time from school and them to lose time from work. So what treatment should be considered for children who are unresponsive to initial treatment and or who have persistent or chronic ITP? So I'll start just by defining some terms. Persistent ITP now represents patients between 3 and 12 months, and chronic is beyond 12 months. And refractory refers to a patient's individual response to first-line therapy. So for this group of patients, we have the option of splenectomy, which has been our historical treatment, rituximab, thrombopoietin receptor agonists, use of additional immunosuppressive agents, of which the list is very long, including things such as MMF and 6-MP, danazol, dapsone, vincristine, azathioprine, so a very long list, and then also ongoing observation. So to come to splenectomy, this has been our historical treatment for chronic ITP. It works on very basic principles that were that we are removing the source of antibody-coated platelet destruction by the Fc receptors that are in the macrophages within the spleen. It's very successful therapy with complete remission rates across studies of approximately 75%. And unfortunately, we don't have any consistent predictors of response. So it would be great to be able to predict if a child's going to be in that 25% that doesn't respond before putting them through the procedure. And unfortunately, we just don't have anything to guide that yet. The other concerns are over loss of immune protection. There's a hazard ratio of about 0.6 within the first year, and then it drops to about 2.5 beyond that. This has likely been reduced in a more modern era with better vaccination practices as well as lifelong antibiotic prophylaxis and fever precautions. And then newer concern has started to grow around this issue of vascular complications following splenectomy. And in this setting, this has mostly been characterized in other hematologic disorders, so disorders such as hereditary spherocytosis or thalassemia. And that becomes important to note because we don't know what role ongoing hemolysis following splenectomy plays in the development of the vascular complications. So it may be that this is more related to ongoing hemolysis, and in which case would not be an issue or a concern for patients with splenectomy following ITP. So in taking in all the evidence surrounding splenectomy, the ASH guidelines recommended splenectomy for children and adolescents with chronic and persistent ITP who have significant or persistent bleeding, lack of responsiveness to first-line therapy, or a need for improved quality of life. And it was suggested that splenectomy or other interventions with serious complications could be delayed for at least 12 months unless accompanied by more severe disease, unresponsiveness to other measures, or for significant impairment in quality of life. So following splenectomy, one of the other interventions that's been primarily studied in a more prospective, larger fashion is rituximab. And this is a B-cell therapy. And it's aimed at basically the CD20 monoclonal antibody that attaches to CD20 and breaks down our autoreactive B cells. And hopefully as these regenerate, they've sort of lost the trigger to create these antibodies. So rituximab has great induction rates in pediatric trials, anywhere from 57 to 68%. In one of the largest trials, complete response was seen in 30% of patients and a partial in 30%. But what was nicely shown in a blood paper in 2012 is this graph here showing that really the durable remission rate drops to 26% about 5 years out from treatment. So we have some limits to using rituximab. And the first is that we really don't have any dosing studies that are available. It's possible that we're overdosing. It was first studied in cancer settings. We used the same dose of 375 milligrams per meter squared for 4 weekly doses, but we really don't know if that's necessary. It's possible we could get away with lower doses, and some of that has been investigated in some smaller studies. It's not benign therapy, so about 12% of patients across all studies experience some sort of significant therapy-related reaction. And these include infusion reactions, more significant development of serum sickness, and then possible infection risks such as viral reactivation. It also takes time to have a response with rituximab, so this is not an appropriate therapy for a child with an acute bleeding presentation or somebody where bleeding may be their main indication for treatment. And then as I've shown in the previous graph, long-term remission rates are less than that with splenectomy. So based on this information, the ASH guidelines were able to suggest that rituximab be considered for children or adolescents with ITP who have significant ongoing bleeding despite treatment with first-line therapy, and that it be considered as an alternative to splenectomy in children and adolescents with chronic ITP or in patients who do not respond favorably to splenectomy. But as you can see, these are both very low-grade recommendations, which is why we use the wording we suggest. They both received a grade 2C, meaning a low level of recommendation based on some weak evidence. So now for sort of the what's new, and this is focused around this notion that we've learned that these antibodies interact with glycoproteins on the megakaryocyte surface. And what was shown was that IgG from patients with ITP can bind to and suppress megakaryocytes. And actually, they induce abnormalities in the bone marrow that are consistent with apoptosis and inflammation. So the thought process was perhaps if we could stimulate the megakaryocytes using TPO, the sort of endogenous stimulator of protein, of platelet production, maybe we could overcome this. So there's two agents that are currently available. Remipalstim is given subcutaneous weekly, and L-thrombopag is given PO daily. In the United States, L-thrombopag did just get an FDA indication for use in pediatric patients. Both agents across pediatric and adult studies have been shown to increase the platelet count, decrease our bleeding events, reduce additional medications, and improve our quality of life for patients. It is important to note that discontinuation will result in thrombocytopenia. So this is not considered curative therapy. When you stop the drug, in the majority of patients, their platelet count will decline again. And in some instances, there's actually something called rebound thrombocytopenia, where the platelet count will go lower than baseline and may even result in bleeding symptoms that were not present before. Reports suggest there's no cross-resistance between these drugs. So if you have a patient who's failed one agent, it is reasonable to try them on the other before just saying they don't respond to TPO agents in general. So Remipalstim has been studied in one randomized pediatric prospective trial of 22 patients. A platelet count greater than 50,000 on 2 consecutive weeks was used as the primary outcome, and this was seen in 88% of patients in the Remipalstim group and 0 in the placebo group. It was also shown using a quality of life measure to significantly reduce parental burden. The median weekly dose was 5 mics per kilo. The max dose that we're allowed to give is 10 mics per kilo, so it does seem that children don't need quite as much as the maximum dose, and there were no serious adverse events that were reported. This was followed up by an open label and a follow-up extension study, and in these two studies, the peak platelet count greater than 150,000 was used as the primary outcome, and this was seen in 95% of patients. The median percentage of weeks that the patient had a platelet count greater than 50,000 was for 84% of the visits. And concurrent ITP therapy was greatly reduced over time in patients, and there were no serious adverse events that were again attributed to treatment. I like this graph. I think it visually shows sort of how to interpret the data, but basically this line here represents a platelet count of 50,000. And what you can see is that if we look at the group as a whole, over time the majority of patients were able to maintain a platelet count shown by these open circles that was over 50,000, and it was very rare that our bars even extended down below 50,000, perhaps maybe a little bit later after use. So L-thrombopag, there were just 2 recent publications, both the PETITE and the PETITE-2 study, and they showed very similar findings. So the PETITE study looked at 57 patients. These were, again, mostly chronic patients with a few who had persistent disease. And they looked at a 7-week double-blinded treatment phase and used a platelet count greater than 50,000 for over 60% of the visits between weeks 2 and 6 as a primary outcome. And this was seen in about 40% of patients who received L-thrombopag and in none of the patients receiving placebo. A platelet count greater than 50,000 at least once during the first 6 weeks was seen in 62% of patients. And then they went on to do a 24-week open label period and again used a primary outcome of a platelet count over 50,000 at least once, and this was seen in 80% of patients. There was again a reduction in bleeding events as well as the need for concomitant medications. And so when we look at the TPO RAs, basically what we see is that we have good evidence for efficacy, but we do have some side effect signals that, while not picked up mainly in the pediatric studies, have been identified in adult trials. So these include the development of bone marrow reticulin. This has been mostly studied in the adult extend study, and what they found there was that there's no grade 3 reticulin development. no symptoms of bone marrow dysfunction, or a blast count greater than 3%. And the reticulin development does appear to be reversible upon drug discontinuation. And I think it's important to note that a lot of times reticulin can be seen just even in the setting of autoimmune conditions such as ITP, and can even be present at baseline. There's also concern for thromboembolic events. These were not detected in either of the pediatric trials using romipilstem or L-thrombopag, but there is an event rate of about 4 per 100 patient years out of the adult trials. And there's increased comorbidities in adults that we have to appreciate that might be leading to this, because again, they've not been demonstrated in pediatric trials. And then L-thrombopag of specific is associated with hepatotoxicity. In the PETITE and PETITE-2 studies, there was an incidence of the development of some elevation of the AST and ALT, but it was reversible with drug discontinuation. But it is recommended that monitoring of liver function occur while a patient is on L-thrombopag. So the limits of the TPOs mainly stem from just not a lot of pediatric data. So there's only been a trial in 22 patients that's been reported for romipilstem. The PETITE trial was roughly 50 patients, and PETITE-2 was about 90 patients. And that goes along with just these were focused on patients with chronic ITP, which is a very rare group and difficult to recruit. There's also difficulties with administration. So romipilstem must be given in a physician's office currently. It is an injection that's given weekly. And then L-thrombopag has significant dietary restrictions where it has to be sort of timed with meals, and also has to be timed around milk intake, which might be difficult in our younger children. There's the cost associated with these drugs. So again, because they're not curative therapy, we sort of don't know indefinitely what it costs to leave patients on these drugs. I think some of the long-term side effects still need to be established. This is growing primarily as adults are on these drugs for longer and longer time periods. There has been some data to suggest that safety signals don't seem to shift over time, or that there haven't been new safety signals even in adults that have been on these for a very long time. It's important to remember, though, this is not curative therapy, so in most cases, again, just to stress, the platelet count will return to baseline or even below within about 2 weeks of drug discontinuation. There have been reports of patients that have gone into remission following use of the TPO-RAs, but I think that this is really hard to tease out if that was just the natural course of that individual's treatment, or if it was truly related to some sort of immune modulation that might be provided by exposing patients to very high levels of platelet counts over a long period of time. So to summarize second-line management, we can offer splenectomy, which removes the source of platelet destruction. Induction rates are roughly 80 to 90%, and long-term remission can be achieved in about 60 to 80% of patients. Rituximab results in B-cell depletion, and there's maybe some evidence to suggest it also induces some T-cell changes. And induction rates are good, with about 50 to 70% of patients responding up front, but long-term remission is projected to be much lower at about 20%. And then we have the newer thrombopoietin receptor agonists, and these work by increasing platelet production. Induction rates are seen in about 40 to 60% of patients, but we can expect a durable response once the drug is discontinued. So in the absence of significant data, how do we make a decision? Well, I think that we need to look at what is our current landscape. So we have a lack of randomized trials, and it's unlikely that we're ever going to have a significant number of randomized trials, given how diverse these different treatments are. Even outside of randomized trials, there's a general lack of pediatric data on many of these agents, and we extrapolate quite a bit from adults. The decision to treat relies largely on the frequency and severity of bleeding and the impact of the disease on quality of life. And the patients may have a preference between therapies based on individual priorities. So a lot of times when I'm talking to a family, I'll always sort of approach the visit the same way, and then I'll start by assessing if there's any bleeding that requires immediate attention and treatment. Then I'll ask about what is the impact of the disease on the family, how many things are they having to miss, are there things that the child can't do, what is their anxiety level or their worry level about their child. And then lastly, we'll talk about what the platelet count is and how that might impact what we're doing. And I think it's important to really stress that I think this involves a lot of patient decision making as well. I think it's a decision of understanding what the priorities are of that individual patient and family. So what we're really trying to assess by the end of each visit, and what we really want to know to make the literature better, is what's the true severity of disease or the risk of bleeding, and what's the negative impact of treatment. So do we have a reason to really suggest that we shouldn't be providing treatment for every patient? What are the costs of our medications? How should this impact our decision making? How do we look at this to be cost effective? And then how do we address the priorities of our patients and families? Because overall, really what we're interested in is what's the impact of the disease on our individual patient that's sitting in front of us in the clinic. So I think there's some new research strategies that we can use that help us address this. So the first is looking at health-related quality of life. And Rob Klassen out of Ottawa has really developed a very nice pediatric ITP quality of life tool called the KIT. And it's been used in both of the TPO receptor agonist trials. We can also look at cost analysis, and this assigns different qualities to different strategies and looks if there's one overall approach that seems to be the most cost-effective when accounting for everything else. We can use models like comparative effectiveness, and I'll give an example of this in a few upcoming slides. And this looks at a direct comparison of strategies to determine if there's one best strategy for patients, and it's really trying to balance all the benefits and harms. So it looks at cost and side effects as well as any potential gains in quality of life or symptom relief. And then I think it's important to never forget that we can still utilize qualitative methods and simply go back and talk to our patients and families. Victor Blanchette and the group out of Sick Kids has done a very nice job of doing some early focus group work with patients who have been diagnosed with ITP and really understanding their experience and what their thoughts are regarding a treatment approach and strategies. So I'd just like to conclude by wrapping in a little bit of an example of comparative effectiveness and how collaborative efforts may help improve what we know and how we treat patients. So the Pediatric Consortium of North America, or ICON, is a collaborative research effort really aimed at improving treatment and quality of life for patients with ITP in a collaborative manner. So this is something that if your center is not currently participating in, we're still looking for others to join our group, and I would love to have you reach out to us and work alongside us. Our main study that's open and accruing patients right now is ICON 1. The title of this study is Physician Treatment Decisions and Patient-Reported Outcomes in Pediatric Refractory ITP. And so this is a longitudinal cohort study of pediatric ITP patients that are started on second-line treatment. So unlike prior studies that have really focused on the duration of disease, being either studies in chronic ITP or acute ITP, we're really more interested in any child receiving a second-line therapy. So it doesn't matter if that patient is 10 days out from their diagnosis or 18 months out from their diagnosis. We'd like to collect information. And we're mostly interested in decision-making factors. So there's actually a questionnaire for the physician asking what went into their decision-making in selecting that agent for that child. What is the treatment plan? What follow-up is expected? They're collecting patient-reported outcomes, so symptom measures, fatigue measures, as well as quality of life. Bleeding assessments, so looking at a clinical outcome, and then also the platelet count as a laboratory outcome. And some of the objectives are to model factors that determine physician treatment decisions in selecting second-line agents. We're looking to assess patient-reported outcomes with relation to a specific second-line therapy and determine comparative effectiveness of second-line treatments, mostly looking at bleeding symptoms and platelet counts. So when we look at a strategy, I think hopefully I've presented several things that need to be considered, and I think we need to look at what is our potential benefit. What are we trying to gain in this patient? Are we trying to achieve a very quick increase in the platelet count, looking to reduce our symptoms and the need for additional medications? Are we trying to achieve an improved quality of life? And really, how does our family define quality of life? What is it that is important to them and what that looks like? Or are we really trying to get this child into remission? This all has to be balanced against potential risks such as the adverse effects, the cost of medications, the inconvenience of either weekly visits or daily medications. And then I think that there's a whole nother growing body of literature that could take up an entire second talk on sort of what patient factors can we use to tailor therapy. So the duration of ITP matter. Some agents may be more effective if we use them earlier. What contraindications do we have? So for example, with TPOs, should we consider other risk factors for thrombosis when looking at that as an option? What previous treatments have been tried? If this has been a patient that's received multiple types of immunomodulatory therapy, then perhaps switching to a TPO makes sense. But then lastly, I think there's a lot of interest in can we use any biological or immune factors to really predict patients that are going to show response to different agents, and how can we maybe tailor treatment based on a profile of our patient in terms of what's going on the immune level. So in conclusion, severe disease is rare in pediatric ITP, and management can often consist of observation. The rationale for treatment should include consideration of patient-related outcomes. There's little evidence to guide current management and guidelines, and knowledge about physician and patient decision-making may help us inform future research. And I'd just like to give some thanks to Thomas Cooney and Paul Imbach, who have really spearheaded the efforts of ISIS. And as I said, they've enrolled over 4,000 patients to date and have really contributed substantial amounts of information to the literature. And then ICON was the kind of brainchild of Ellis Neufeld and Rachel Grace at Boston Children's, and Rachel Grace is actually the principal investigator of the ICON 1 study that is open and enrolling patients. I'd like to acknowledge the American Society of Hematology for making ITP one of their primary efforts in terms of guideline development and education. And then, as Leo mentioned in the introduction, I had the privilege of training with Dr. George Buchanan, who has served as such a mentor to me in all of my work in ITP. So I will stop there, and I think we have left some time for questions that Leo will help facilitate. Thank you.
Thank you very much, Cindy, for this very, very clear explanation about this interesting condition in kids. Now we have more than 20 logins, plugins, if you will, and it would be a bit challenging for me to go one by one. So I would do it going from west to east again, and please feel free to also raise your hand so that I can see in the computer and I can unmute your microphone if that's the case. So I'll start with centers in Saskatchewan. I see Dr. Singha is logged in. I don't know if Runa has questions for us. Runa, the mic is yours.
Exactly, yeah. So I will forward it.
Can you hear us, Runa?
Yes, that's good, because I guess I wanted to get that, like, so the other thing is that the October 31st was when we had to submit our resignations.
So maybe there wasn't a question. And I'll go to Manitoba. Let's see, I see Dr. Doyle, and hi, Dr. Doyle, do you have a questions for us? Maybe not, Cindy. Not everybody has a mic.
Okay.
Let me break that to see if I'll jump in to see now in Ontario if we have any questions from the 4SC Kids. So let me open the mic for questions done at SICK Kids. Any questions here? Please come at your microphone to ask the questions. I'll remind you.
Yeah. Hi, we have a question here.
Please go ahead.
Sir.
Yeah. So regarding the splenectomy, we need a partial splenectomy or a full splenectomy. This is one, and another one is that whether dexamethasone or prednisone, which one is better?
Yes. So the first question was regarding if partial splenectomy works, and we don't really have any evidence yet for partial splenectomy. I think that definitely we do have evidence that we can proceed with laparoscopic, which has certainly made splenectomy safer, but I think at this time still the standard is to do full splenectomy, and in fact we even know that patients that leave behind a small amount of an accessory spleen can still have ongoing ITP. There is some work being done for partial splenectomy, as I'm sure some of you know, in other conditions such as hereditary spherocytosis, and perhaps we can glean something from that, but I really think that for now the standard is to go ahead with a full splenectomy, knowing that even if we leave behind a sort of accessory spleen or small amount of splenic tissue, the platelet count can continue to be persistently low. And the second question was a question of dexamethasone versus prednisone, and this comes up quite a bit, and it's mostly stemming from adult literature. And that literature, there was a lot of crossover and a lot of difficulty in the way that the dexamethasone study was finally conducted, and I think that there's really not adequate data yet to say that one is better than the other. I think there's still ongoing literature that's going to be coming out about this, ongoing studies. I don't believe that there is any pediatric literature that's comparing the two. There is some data to suggest that for patients refractory to first-line therapy, high-dose dexamethasone can be considered as treatment. However, in those studies, oftentimes kids weren't able to tolerate the full courses of such high doses of dexamethasone. But at the newly diagnosed stage, the main debate occurs in the adult population because it's whether or not shorter courses of dexamethasone can be used versus in the adult setting where they give almost a whole month of prednisone, inclusive of a taper. So in pediatrics, really I favor a short course of prednisone. And I use prednisone, and to my knowledge, there's nothing to really suggest that dexamethasone would be a better agent in that setting.
Thank you so much.
Thank you very much. Are there any other questions from the floor at Sick Kids? If not, Cindy, I may ask a question before we go to Quebec and Halifax. It was very nice to see the graph that you showed us, the platelet response to TPO mimetics, but do we actually know the effect of TPO mimetics in terms of bleeding reduction in children?
Yes, so they actually, across all the studies, sort of a secondary outcome and analysis has been to look at bleeding reduction. Most of them use the WHO bleeding score, and we're able to show that the incidence of sort of grade 3-4 bleeding does decrease with the use of the TPO agents. And this is pretty consistent across L-thrombopag and Remipelstem, and across adult and pediatric trials. So it does appear that that increase in platelet count is also associated with a reduction in bleeding symptoms.
Thank you very much, Cindy. If there are no further questions from Sick Kids, let me try to open. Let's see if we have questions from colleagues in Ottawa. Ottawa, you have a mic open. Any questions from Dr. Schlosser? Doesn't look to have a mic. Let's see, now we go to Quebec. Let me try to open the mic in Montreal. Dr. Papasparos, are there questions there? Nope. Then we will go to Halifax with Dr. Vicky Price. Vicky, thanks for joining us. Do you have any questions for Cindy? It doesn't look like we do. Any final comments, Cindy?
No, I really want to say thank you for the opportunity to speak with everybody this afternoon. And if there are questions that anybody has, you know, please, you can reach out to me by email, and I would be happy to answer them.
Let me just see, make sure I don't have any questions on screen. Dr. Crystal Raymond, we opened your mic from Ottawa. We have a question.
Yeah, no, that's actually our admin assistant. Crystal is the admin. So
hey Rob,
Rob,
how are you?
Good, good. All I wanted to say was Cindy, you did a fantastic job. It was a really nice overview. I appreciate it, and I just wanted to highlight the fact that Cindy is the chair of ICON and is doing an amazing job, sort of doing research in ITP. And I certainly encourage everyone to really get on board, because I think it's the way forward.
Thanks for that plug, Rob. I really, we would love to have everybody join us. You know, in pediatrics, much of what we do involves rare diseases and rare conditions, and so working together, I think, will definitely accomplish more great things for our patients. So I encourage everyone who is not part of our group to reach out and join us.
Excellent. Thank you very much, Cindy. It was a pleasure, and we'll be resuming on January 12th at 3 p.m. when Dr. Myro Tressler will be talking about optimizing warfarin management in Canada. Until then, wishing everybody a good holiday season. So long.
Goodbye.